Welcome everyone. This is the MRL Diagnose and Treat Your Research Problems, Session 8. Our today's presenter will be Dr. Tsagga Waldamariam. He's a medical doctor and AMGH candidate at Arba Min General Hospital. He is going to present a research thesis on the incidence and predictors of multimorbidity in adult people living with HIV. On treatment at Arba Min General Hospital in Ethiopia. It is a retrospective follow-up study. And our external reviewer is going to be Professor Dawit Weldai. Professor Dawit is a medical doctor and a PhD holder in immunology. He has over 3 decades of research experience in infectious disease, multiple areas, including HIV/AIDS. He has worked in multiple places in Ethiopia, and research institutions, including EPHI and healthcare facilities. And in addition to that, he has been serving as an editorial board and reviewer of different peer-reviewed international journals. The list is very long, since we all want you to learn more about Professor Dawit. I have shared you his full profile, the link to his profile on the chat box. Please, you can go through that. So in addition to that, something that we all can learn, and some special thing about Professor Dawit is that he not only inspires other researchers through his career and through his teaching. In addition to that, he brings a lot of grant to the country and made it possible to conduct so many researches that would have otherwise been very difficult to conduct, considering the research budget and resource that we have as a country. So we're glad to have you, Professor, today. And for the internal reviewer, I'll be taking the part of the internal reviewer. And my name is Tigist. I'm the founder and general manager of Medical Research Lounge. Thank you. Thank you, Dr. Tsagga. You can start your presentation. Dr. Tsagga, your mic is mute. Yeah. Great.
Okay. So the research title is The Incidence and Predictors of Multimorbidity in Adult People Living with HIV Receiving ART Treatment at Arba Min General Hospital, Southern Ethiopia. It is a retrospective follow-up study. This is the outline, introduction, significance, and conceptual framework. And finally, we have a reference. Let's start from the introduction. Globally, the last decade has been exceptional growth in the coverage of ART program. So due to the success of ART, the cohort of people living with HIV has been gradually aging. This in turn raises the risk of having multimorbidity among them. So multimorbidity is defined as the coexistence of 2 or more long-term conditions where each must be non-communicable disease, mental health disorder, or infectious disease of long duration in the same individual. The evidence suggests that people living with HIV develop severe multiple long-term health conditions at early age than the people not living with HIV. However, multimorbidity can be present in all age groups, rendering it a widespread public health concern. The burden of multimorbidity is higher in people living with HIV than general population at all. The gap between the two populations widened with age. By year 2013, 84 and 28% of European people living with HIV are predicted to have greater than 1 and greater than 3 comorbidities, respectively. Over 69% of people living with HIV estimated worldwide were found in sub-Saharan Africa. So multimorbidity is much more common in private groups. Such complex multimorbidity is a major challenge to the existing model of healthcare delivery. In 2018, the Academy of Medical Science acknowledged that multimorbidity was a global research priority, as populations are experiencing multimorbidity in a large scale. They also highlight the inadequate nature of research into multimorbidity, especially in middle and low-income countries. So little is known about the incidence and predictors of multimorbidity, particularly in adult people living with HIV receiving ART. Significance for health professionals. It will help them to understand how common multimorbidity and what factors are associated with developing multimorbidity. Therefore, this information will help them to understand the challenge that this population faces and also help them to develop ways to prevent and treat multimorbidity for health issues. The finding will be used to inform resource allocation and service planning, and to develop more targeted and effective intervention. For policymakers, it can be used to develop and implement effective strategy and to prevent multimorbidity in adult people living with HIV in low-income country. For researchers, can be used as baseline information, since this study include wider range of multimorbidity based on the wide range of chronic disease. This is a conceptual framework. As you can see in the center, there is multimorbidity and people living with HIV, and there is social demographic variable, clinical related variables, and behavioral related variables. This is a research objective generally to identify, to determine the incidence and predictors of multimorbidity among adult people living with HIV. So the specific are to determine the incidence and to identify the predictors of multimorbidity among adult people living with HIV. In the methodologic session, the study was conducted at Urban Hospital from January 1, 2008 to July 13, 2023. It was a hospital-based retrospective follow-up study was conducted. Adult people living with HIV age greater than 80 started their return were followed from January 1, 2008 to December 13, 2017 at Urban Hospital was the source population. The study population are those who fulfill the inclusion criteria. Among the source population will be the study population. The inclusion criteria was those with no baseline multimorbidity, and those who have at least for 5 years on ART will be the inclusion criteria. So the exclusion criteria is people with no baseline information recorded and lost documentation who doesn't fulfill the inclusion criteria also could be the exclusion criteria. Sample size determination, the sample was determined using Stata version 40 statistical software, considering 95% confidence interval and 5% significance level, 80% power, using 3 predictor variables from previous study conducted in Brazil. So the final sample size calculated was 606. This is a table for the 3 predictor variables, which was found from the study done in Brazil. So sampling procedure, initially we do have 1,544 participants. Among those who has a baseline multimorbidities around 467, they are excluded. So those who fulfill the inclusion criteria is 1,077 using computer generated methods of table of random number. 606 were recruited to the study. Among those 606 who doesn't have baseline information, those those medical record were excluded from the final analysis. So this is the study variable. So the dependent variables are multimorbidity, the independent variables are social demographic variable, clinical rated, and behavioral mentioned in the slide. The operational definition, when we say event, there is occurrence of multimorbidity. When we say sensor, those who lost follow-up, who transfer to other health facility, who didn't develop multimorbidity until the end of the follow-up period. Survival status are the outcomes of adult people living with HIV, either develop multimorbidity or censored the survival status. Time to multimorbidities, the time from the initiation of ART to developments of multimorbidity will be the time to multimorbidity. So data collection procedure. Data abstraction tool was developed after reviewing different literature and using national guideline for HIV/AIDS by following important steps for developing RR or retrospective record review formats. So the record were reviewed. For baseline multimorbidity status before data abstraction. So adult people living with HIV age greater than 80 years who meet the inclusion criteria. Both medical and electronic file were reviewed retrospectively by data abstractors. Data quality control and the pre-preparation phase. Trainers was used for data collection. Training was provided. Pilot study was conducted in 10% of the sample. During data abstraction, the principal investigator supervision and daily meeting with each team members to discuss and evaluate data abstraction process. After data collection, consistency, completeness were checked by Microsoft Excel, cleaning, editing, coded, and tabulated by Stata. Data processing and analysis, data were cleaned, edited, coded in Excel, then entered into statistical software Stata version 40 for further analysis. Categorical variables were described using frequency and percentage, where continuous variable was described using median and intra-quartile range. The outcome variables were dichotomized into multimorbidity and censored. To estimate the survival curve among explanatory variables, the Kaplan-Meier survival curve was used to compare for equality of survival among categorical variables. Log-rank test was used. Bivariate, Bose, Cox, and Gompertz regression was fitted. Those independent variables that become significant on bivariate were with a level of significance of 0.25 were included in multivariate regression. So the effect of the explanatory variables on the incidence of multimorbidity following AT initiation was determined using the multivariate regression. So multicollinearity of independent variables was checked by variance inflation factor, VIF. Akika information criteria was used to compare the parametric model, since some of the variables violate the proportional hazard assumption. There will be a model extension. During that time, to select the best fitted model, Akika was used. The overall goodness of fit model was checked by Cox-Snell residual test. Ethical consideration, the ethical clearance was obtained from the Ethical Review Board, College of Medicine and Health Science, AMGH University. Verbal consent was obtained from the hospital administrator. Confidentiality of any information provided was maintained by excluding name from the identification. So regarding dissemination plan, the study finding will be submitted to the AMGH University, the Amazon Health Bureau, Regional Health Bureau, and the other interested governmental and non-governmental organizations. It will be also sent for publication in scientific journal for timely dissemination of the study finding to the relevant organization and stakeholders. So let's go to the result and discussion. So the descriptive part, social demographic factors. Majority of the total sample, majority of the study participants were female, which is around 63%. The median age was 34. Regarding the educational background, almost 39% have primary education, whereas 28% they have no education. Almost close to almost 10% had tertiary and above education. Regarding the religion, most of the study participants were Orthodox in religion, around 62%, where 29 and 8% were Muslim and Protestant respectively. Regarding clinical related factors, around 33% of the study participants were WHO stage 3, whereas 54% are WHO stage 1 and stage 2 at quaternary. Majority of the participants, around 96%, had peak viral load less than 100,000 copy per ml during the follow-up period. Around close to 90% had current viral load less than 50 copies per ml at the end of the follow-up. Of the entire individual who were included in the study, around 90% had good adherence. The majority, about 74% of the individuals completed TB prophylaxis, whereas around 23% never took TB prophylaxis. Of 454 individuals, about 26% had obesity and overweight, and those underweight are around 23%, but almost 50% of the individuals has normal body mass index. Regarding behavior-related factors, a majority of the individuals included in the analysis, around 94%, and almost close to 69% never smoked and never drank alcohol respectively. Most of the individuals, around 87% of the participants are physically active. They love to take a walk regularly. Of the entire individuals, most, around 86%, had a habit of consuming unhealthy diets such as high salt diet, high sugar and fats, and low fruit and vegetable. Regarding the multimorbidity and the specific health condition which was seen over time in those study population, most of the most common chronic health condition evaluated were anemia, which is around 53%, dyspepsia 34%, infectious disease, TB and hepatitis 21%, hypertension 19%, neurologic disorder around 7%, rheumatologic disorder around 4%, which is directly comparable with the study done in Southern Ethiopia. To the best of my knowledge, this is the first effort to characterize multimorbidity profile in HIV-infected population in Ethiopia. So one of the most important findings of this study is higher cumulative incidence of multimorbidity in people living with HIV, more than almost half of the study population. Around 55% had 2 or more chronic health conditions in addition to HIV. The same trend was found in a retrospective study conducted in Morocco Referral Hospital, which is around 35%. And another cross-sectional study conducted in Thailand has shown multimorbidity rate of 41%. However, direct comparison are not possible because the several previous studies used a heterogeneous definition of multimorbidity and much more restrictive list of chronic condition. This is the table shows the multimorbidity in a specific health condition. As you can see in the table, the first one is anemia, which accounts about 54% of the comorbidities. And the non-communicable comorbidities, all hypertension, dyspepsia, dyslipidemia, stroke, all includes almost it accounts about 63%. When it comes to the chronic infection, it accounts about 20.7%, which is close to 21%. So the multimorbidity, which is greater to comorbidity in addition to HIV, accounts about close to 55%. Regarding incidence rate of multimorbidity among adult people living with HIV, so the study included 454 people living with HIV on RT who were followed until July 13, 2023, accounts about 62,952 months of observation at risk and representing a median survival time of 178 months. The overall incident rate of multimorbidity was 3.9 per 1,000 months of observation. The incidence rate increased with time and was positively associated with peak viral load, poor adherence, hard drug, tertiary and above education. So the results are in line with other studies done in Brazil, Australia, and South Africa, showing an increased burden of multimorbidity over time in people living with HIV. The predictors of multimorbidity, the current study, tertiary and above educational level was positively associated with multimorbidity. It might be due to the better survival, which will lead to the accumulation of chronic disease over time in this people group. This study showed that peak viral load greater than 100,000 copies per ml and poor adherence were positively associated with multimorbidity. It's quite similar results of what done in Maryland, Ghana, respectively. This study found that people with WHO stage 2, stage 3, and stage 4 HIV has less likely to develop multimorbidity than people with stage 1 disease. This is maybe due to the mortality takeoff. Usually people with advanced stage of the HIV, usually they tend to die. Because of that, the accumulation of multimorbidity will be minimized. Individuals with normal body mass index and BMI greater than 30 kg per meter square had much lesser risk for multimorbidity than those individuals with body mass index less than 80.5. Because most of the time the overweight and or normal body mass index was usually seen in developed nations, since multimorbidity was most of the time it's a problem of deprived community. That's why this is only so it goes with that important discussion. So the study found that people living with HIV who completed INH prophylaxis had low risk of developing multimorbidities than those who never took INH prophylaxis. Age, gender, CD4 nadir at quaternary, and family history of DM, hypertension, smoking, alcohol use were not statistically significant association with the incidence of multimorbidity. However, there were significant association described in other studies done in Morocco, Brazil, and Australia. And this study doesn't show a statistical significant association, but doesn't mean that there is no association, maybe because of uncontrolled other confounding factors. This is the table to shows the multimorbidity, multivariate analysis of factors associated with multimorbidity among adult people living with HIV. So as you can see here, there is Cox proportional hazard and the Gompertz analysis with adjusted hazard ratio and the p-value, and the survival status, VLR and censored. Okay, this is almost discussed. Okay, the other is the log rank test, which is used to compare the survival, the equality of survival among the covariates. As you can see here, these are the covariates or predictor variables, which shows statistical significant variations on the survival status among the categories. As you can see, the survival function. So the first one is the overall survival estimation. So as you see in the graph, it goes progressive decline. Also it crossed the 50 percentiles, which is almost cross 0.5. which shows that majority of the observed participants of the study developed the multimorbidity. Also, it is close to 0, which is also supportive of the observed results. The other thing is, as you can see, the graph almost it declined gradually, but after the months of almost close to 180 months, it declined sharply. Maybe that's because of age factor. Model comparison. And this is a model comparison based on the consistent resistance plots. As you can see, is it fits with the data. Okay. The multicollinearity was also checked with the cutoff 0.5, and mine was the mean VIF was 3, which shows that there is no multicollinearity concern or no correlation between the independent variables. Then in the conclusion, chronic health disorder are part of the issue for this population. Patients who have a mental decline and impairment, however, it's crucial for they should be aware of.
I think we can start with Prof. We can start with you, since the audience can also. It's not Dr. Zagao is not expected to answer all the questions. It's all just to suggest and to discuss on his findings and his methodology. So as soon as he joins back, we'll try to summarize it, but you can reflect your ideas while he's back. So I think you can start.
Okay, so
Dr. Zagao, I think we can start.
The policymaker should take that. Yeah.
Okay.
Okay, the discussion. Okay.
Thank you very much. I think it's just 2 slides to your recommendation. So we can get to it later as well. Dr. Dawit, you can start with your comments.
Okay.
So
Shall I go?
Yes.
Shall I go ahead? Okay, Dr. Tagaw, sorry, despite the problems, you somehow managed it. Always when I review things and I ask the students, it's not to torture you, but it's just to expand our knowledge, myself, to try to understand new things, or clarify things. Okay? Do you agree with that, Dr. Taga?
yes, I agree.
Okay, thank you very much. Nice presentation. I'm fan of cohort studies, longitudinal studies, because most of the students I see, they deal with cross-sectional studies, and this is a very important study. One of the few studies I would say conducted in Ethiopia. So, having said this, in as chronic pre-existing conditions, why didn't you include cardiovascular disease, chronic obstructive lung disease, and other conditions?
Just try to include. Okay, maybe I should go to the slide. As you can see here, I just try to include some of the cardiovascular conditions, but they are few in numbers, so that I just merge into the other. For example, as you can see in the heart disease, there is 8 number. So the ischemic heart disease, hypertrophic heart disease, and hypertensive heart disease, and rheumatic valvular heart disease are totally there are 18 numbers. It accounts almost close to 1.8%. They are few. That's why I just didn't discuss the detail.
Okay, so please include whatsoever you have in the table, include them in the methodology section. It doesn't matter. Even you will find sometimes zero, but it shows the reviewer that you have looked for these specific conditions. But given the fact that it's a retrospective study, you just got what you got from your chart review, the information that was recorded from the charts, but you show to the reviewer that you have addressed this issue. So include in the methodology. Another question, Dr. Tagau, table 3, you have shown greater than 700. Okay, be careful about these numbers. It should be greater or equal to 700. Otherwise, when you do analysis, if you miss greater than 700, you're missing 700. Okay. You mentioned about the median follow-up was 178 days, months, sorry, but I was not able to see the interquartile range. You need to include that. Dr. Yasamano, he disappeared.
Yeah, I think we can continue with the comments.
Yeah, and also there was this good question by Kibru. Why was median and IQR used? And also he asked what was the distribution of the, the data, the variables assessed. And this is very important thing that need to be addressed. Can anybody try on this? No answer?
Kabru, you can also reflect if you want. These are interesting questions. I'm happy with the questions. He also asked about the multicollinearity. One of the other big issues in the research is multicollinearity is assessed for categorical variables and VIF results are presented. But this is statistically not correct. We have a senior statistician with us, by the way. He can also comment. So how was it done for a categorical variable? That's one question, a very important critical question. So maybe if he wants to reflect, we can give him the chance. Kabru, would you like to say something?
I think Duguma has responded it nicely. Yeah. We usually do normality assessment, then if that fails, it's better. If the distribution is skewed, then we opt for median rather than the mean. I think that's a good answer. What I like in the data is that when the median follow-up of 178 months, it's nice to put in brackets the interquartile range of the median so that you show, what was the minimum months of the follow-up versus the maximum months of follow-up. I don't know, maybe the statistician who was involved in this could help us. How was censorship done in this study?
Actually, the statistician is just an audience not involved with the research. I'm just
Okay.
referring that if we can have some help if we need. So censorship, he defined censorship, maybe I can take it. He defined censorship as those who did not develop multimorbidity during the study period or during the observation period, or those who died before that, before developing multimorbidity, or were lost to follow-up or transferred to another hospital. That's how he defined it. And one good thing that was missing on his submitted paper, but is included here, is that he used the minimum observation duration of 5 years, which is good. That was one important question, because if enough observation time is not provided, it might lead to it might result in few events, and that might be reflected on the analysis result and everything. So he has allowed 5 years. The minimum observation period was 5 years, I guess.
Yeah, that's good. For longitudinal studies, we censor patients, as you rightly said it, when patients are lost to follow-up or when they die, and also when we lock the data, we stop the study. So we cannot control beyond this. We don't know what happens after we stop the study. The patient can die or can potentially be lost to follow-up, but we don't mind as far as we stop the study. So these are the things when we censor follow-up of individual patients. Unfortunately, Dr. Tagaw is not here. I was going to ask him whether he really understood the definition of multimorbidity in his study. Yeah, he mentioned more than 2 chronic conditions. Yeah, am I right?
Yes, it's defined like that.
Okay, so it would be nice to have one table showing a breakdown of the assessment of the multimorbid conditions. The combination of the different diseases. I can see he has a very high rate of diabetes, hypertension, and so on. And it would be nice to show in another additional table, like, is it hypertension, diabetes mellitus, chronic liver disease? Is it hypertension, obesity, kidney disease? And then to try to ascertain also the differences in risk factors in this different combination of diseases. Does that make sense, Dr. Tiggs?
Yes, definitely. That's also one of the questions I had. Yes.
Yeah. So he needs to show the breakdown, the details, including differences in risks between the different combinations of, like you can have a cluster of, like cluster 1, hypertension, diabetes mellitus, chronic liver disease, like cluster 2, hypertension, diabetes, chronic kidney disease, cluster 3, 4, 5, and so on. Then he can try to see whether there is a specific risk for a specific cluster. We had shortage of time. but I saw there were certain limitations that he mentioned in the study. For the audience, what do you think is the major limitation of such kind of studies, or this study specifically? Anyone who wants to answer this question? Secondary data, correct. But I would give 50% for this. I think the major limitation of this study is given the fact that this study is a retrospective study, and then we cannot control the variables. We just can, we can analyze data which is already available. But if you really design a study which is prospective study, then we can control what type of variable we can include a priori. Yeah, and that makes our study more quality. That is the beauty of longitudinal prospective studies, and that's why they are expensive. So there is a lot of bias in terms of retrospective study, because a variable that has not been assessed could indeed be a risk factor. Yeah.
Dr. Zagao is back. He can also interrupt. Dr. Daud, you can continue with your comments.
Yeah, I have included also all the most important questions that I would like to ask him in the chat box. And Dr. Zagao, are you back with us?
Yeah, I think he has also joined with another device, but that's great. I think the questions are really
The questions are, yes.
He can also get it, and the audience also can get that. So if you have other remaining questions, you can also reflect on that, and I'll add a few things, and he will get it from the recording. Prof, do you have any? Are you done with your comments?
Okay, yeah, these are the major things I want to discuss with him.
Thank you. Okay, maybe I can add a few and he'll get that. One of the concern I had was with regard to actually the outcome variable. There seems to be, he seems to interchangeably use the outcome itself, the incidence of multimorbidity, with the time to the development of multimorbidity. And that is even reflected on the interpretation of his results. So if he's actually looking for the incidence of multimorbidity, the analysis method that he should be using, the interpretation and everything should be completely different. But it seems like what he actually is interested in is considering his operational definition and other things. He seems to be interested in the time to the development of multimorbidity. So with that regard, most of the results he obtained, and that's presented on the table, has a lot of issues. I can display that and we can see it together. So in addition to that, when we use Cox regression, the conventional method, the assumption is that all the variables that we use are not time varying. Rather, they are variables at the start of the study, at the beginning of the study. But there are so many variables that are included in the study which are time dependent, including CD4 count, change in viral load, hemoglobin, and even ART adherence. How was that assessed? Because if they are newly enrolled patients, these are time dependent variables, and instead of just the normal Cox regression, he should have considered the time dependent Cox regression model. The other most important part is the sample size. I don't know if you have noticed it, but he calculated a sample size and he has obtained 606 total sample size required. That means to answer his research question, he needs 606. I don't know, maybe he considered a 10% non-response. So a 10% loss is acceptable. But what he has actually included in the study is 454, which is above 10% loss from the calculated sample size. So this is not acceptable. Rather, the most appropriate thing to do was to include all eligible patients during the study period. Actually, one of the rules for retrospective studies, as long as the data is already collected and available, unless resources are a constraint, the most appropriate thing to do is taking all participants. And if it's a small sample size, or even if it's large, we can do a post-hoc power analysis and see if our study was adequately powered enough. But with a prior sample size calculation and with a loss of more than 10%, if he submits this article for a journal, the first question will be, your study is not adequately powered because your sample size is lower than the calculated sample size. So I don't know how this is going to be handled, because the problem is like clearly seen, something that could have been avoided, but was not. So that is a big problem. And the other is, as Kibru clearly stated it, properly stated it, multicollinearity for categorical. All of the variables are categorical, but multicollinearity VIF test was done. And this is, statistical software is called garbage in, garbage outs. Okay, Zaka, you're back. I'm glad you're back. So the statisticians call it garbage in, garbage out, because statistical softwares, whatever you give them, they can give you back the answer. So if your categorical variables are labeled as a numeric, on a numeric scale, or as a numeric variable, and if you ask the software to give you a VIF result, it will give you, but that doesn't mean it's appropriate to do a VIF test on a categorical variable. That doesn't have any statistical justification. And the continuous variable, the choice of using median or mean should be justified. That's not, again, clearly stated. And the other is, you have calculated cumulative incidence and at the same time incidence density. What was the necessity of calculating both? For your study, which one is the most appropriate? So this was one of the question I wanted to ask earlier. So for a cohort study, for a follow-up study, we use incidence instead of prevalence because we're measuring new cases over a period of time from at-risk population who are there at the beginning of the study. So based on the nature of the cohort, whether it's open or closed cohorts, we decide to use whether cumulative incidence or incidence density. So Dr. Zaga, why did you use both cumulative incidence and incidence density? Which one is the most appropriate for your study? Oh, Dr. Zaga again disconnected. So both of them are calculated. Just because we have the statistical tools again doesn't mean we have to use them all. We have to exploit them all. His study, as we clearly see it, was an open cohort. Open cohort means patients enter into the study at different times, and they exit the study at different times, and they have different observation duration. So it's not like we enroll a group of patients and we follow them for equal amount of time and we stop the study while everyone is in there, like a closed cohort. Since it's not that, the most appropriate thing to calculate is incidence density, and that should be reported. And the other is on his comparison of the incidence rate between groups. It was mentioned that some of them are significant. Some of them, the variables have significant difference in terms of their incidence of multimorbidity, like the body mass index and others. But without running at least the crude incidence rate ratio for that particular variable, we can't say, without having a statistically significant result, we just can't say that there is a significant difference by seeing the numbers, right? Statistics is not similar with mathematics. 3 could be equal to 2 for some summary measures. So we need to use the statistical cutoff points and declare statistical significance difference based on that, not just by seeing the numbers and saying that there is a significant difference. So that's not based on acceptable result. So the other thing that I want to see is the regression table. It's very interesting. I wish Dr. Zaga can join us. Yeah. This table, you can see it, right? You can see the screen, right? So here, most of the variables, I mean, you should be asking, most of them do not make sense. So how do you interpret this result? The result that's associated with religion. You can see my screen, right?
Yeah, yes, we can see.
Okay, thank you. So how do you explain this result? What's the necessity of running religion as a factor to begin with? So it says that Muslims have an increased hazard of developing multimorbidity, and Protestants have, I don't know, 66% lower rate of developing multimorbidity, and both are significant results. So how do you define that? The other thing here, educational status of tertiary and above is associated with a higher rate of developing multimorbidity, again. And most of the results here for BMI and other things also doesn't seem to go along with what we know so far, the science or the logic. Here, underweight is the reference, and patients within the normal age range that have lower rate of developing multimorbidity. And it's the case for all the remaining groups as well. But when you come to the overweight groups, there is no significant difference with the underweight. But the risk seems to be much lower for patients who are obese. Imagine, look, the normal range group, they have lower hazard, but the obese groups, they have a much lower rate of developing multimorbidity. So it's saying that the obese are better protected groups. So how do you interpret this? I just wanted you to see this result. So does it make sense? I don't know, Dripsa, you're here, maybe you can add. So some of the results are not, when we're interpreting our results, we should
But also, I mean, obesity by itself is, you know, it's an NCD, yeah?
Yes.
So it should be an outcome rather than
exactly
a predictive variable.
Yes, a very good point. Exactly.
It should be removed from the table as a risk factor. It is an outcome by itself, yeah.
Yes, yes, I should have picked that as well. Yes, as being a medical condition, it should have been added in the outcome. Maybe the problem is because of that. The collinearity and other issues are resulting this, and most of the results does not make sense. And even here on the WHO stage, as we go down the stage, like stage 4 patients, they are better protected than the stage 3 and the stage 2. Look, the risk, the rate is like decreasing by the stage. So are we saying that, stage 4 disease? Yeah, so there is definitely some, it needs some revisiting the analysis. Most of the things
statistics is very, very, they call it a diamond lie. The reason is, the sample size. If you see the sample size, you see it's going down and down and down. That's why you see this weird type of association. Sometimes it's nice to collapse them, like you collapse WHO stage 1 and 2 in one, which are mildly kind of asymptomatic. Then you collapse stage 3 and 4 together to get a better assessment. Yes.
Most of the things are usually with data management, as you said. So my concern. Okay.
Dr. Text, I think Dr. Tagai wants to say something. He dropped the text in the chat box.
Okay, he's back. Yes, please. Would love to have you back. Yeah. You can unmute yourself now.
Okay, maybe
we can hear you. Yes.
Mention Karakshu regarding the WHO stage. Regarding the WHO stage, I have some explanation for that. Especially people with advanced stage, usually they die. So because of the mortality takeoff. Therefore, the accumulation of multimorbidity will be minimal because of the risk of dying was likely in this group of people. Am I clear? Yeah, people with advanced stage, they are usually tend to die. That's because of the mortality takeoff. Especially those with stage 1, they will have a better survival. They live longer life because of the ART. But when they are on stage 4 and above stage 3 and stage 4, usually they will die. So they will have low risk of having or accumulation of these over time. That's why the hazard ratios negatively associated with multimorbidity. That's why. Maybe the other thing is
what's going to be very useful. Maybe one thing. So in this case, what something useful is if you can add the observation period for each, yes, logically you can say that, but does it apply for your study participants? Was there a higher death? Was there a higher rate of censoring for your group? You should be able to see that, to show that.
Okay.
Look, the population is like, there's almost a comparable, the failure rate is, for the stage 4 is like almost 50-50, but for stage 3, still the failure is high. Again, for stage 2, the failure is high, right? So yes, you can say that most of the time for patients with terminal illness, severe condition, with severity, we expect death. And if this is not your survival outcome, you might expect a reverse result. But in this case, your failure event is in at least stage 3 patients higher than your censored observation. So I think there should have been at least some sort of pattern. I think it's wise to revisit it. The other important thing is BMI should be in your outcome, not as an exposure variable, in case you have missed that. So please continue with your reflection.
Okay, so maybe regarding the BMI, I just trying to see since the problem of the multimorbidities, as mentioned in the Academy of Medical Research in the UK, they are a problem of deprived communities. Since I'm just trying to see their nutritional status. So those with malnutrition usually, in my study, even it supports those with BMI less than 80.5. Usually they have a high tendency to develop multimorbidity. That's why I just have an issue of multicollinearity if I include it into the outcomes, because some of the variables it will correlate. So to avoid that, just I take the baseline multimorbidity as predictor variables, the BMI as a predictor variables. Yeah.
Okay, the other is maybe your interpretation. So what was your outcome variable? Was it the incidence of multimorbidity, or is it the time that it takes them to develop multimorbidity? Which one is it?
The incidence rate, the incidence density. Yeah, that's my outcome.
Okay, so if the incidence, if what you're interested in is measuring the incidence, why did you run Cox regression or survival analysis in general? Are you what's the most appropriate measure of association? Is it hazard ratio or relative risk?
Hazard ratio. Since this is a survival data, normally the hazard ratio is better regression model, just to see whether there is any occurrence of multimorbidity or not, just during the follow-up period. That's very appropriate one, because survival data usually they have skewed data. It doesn't follow the normal distribution. Therefore, the hazard ratio is the better one, because we don't rely on the relative risk. Relative risk, odd ratio, and the other things are usually practical for those who have normal distribution of data. So it doesn't work for data with skewed or like survival data. That's why I just use the hazard ratio to see the association, or the association between the predictors and the incidence.
Great. So you're saying,
Doctor, you need to be careful in using which regression model for which type of study, okay? Number one, you cannot use odds ratio for this type of data, because your data is longitudinal study.
Longitudinal follow-up.
So we need to be specific. Odds ratio can only be used for case control studies.
Yeah, that's true.
Okay. But here, also I agree with Dr. Tegist. I would use relative risk. By the way, both hazard risk and relative risk are both survival analysis. But given the fact that you have a small sample size, very rare events, then for rare events with small sample size, people use relative risk. Hazard risk is good, but mostly people use it with mortality data analysis, as well as a very huge sample size. You have a very small sample size here. Even you didn't reach the anticipated sample size that you calculated, yes?
Yeah. Of course, I calculated 606. That's the total sample size based on using the predictor variables and the power and the other things. But I just have some loss data. Even those data with loss of 10% variables are excluded. That's what I mentioned in the sampling procedures. That's why just the total sample included in the analysis are 454. It's almost, the response rate is almost beyond 70%. That's why I just proceed with the other explanation, the result parts. I didn't consider as the limitation, because some of the research even they recommend with the 16 and above response rate. But the best one is usually if the response rate is beyond 80%. Mine is almost 76%. 76% of the participants.
So include that in your limitation also, okay? In the discussion section of the text that just mentioned that we anticipated 80% response rate, but it was a little bit lower because we have done so that the reviewer would understand it. In the same table that we saw previously, why didn't you include CD4? You included viral load. You included viral load as predictor here. You see viral load less than 10,000, viral load above 1,000 clearly shows that is a risk factor for multimorbidity. But what about the CD4 count? Both baseline and also Dr. Tegist mentioned it earlier that I forgot. You need also to analyze, time-related events, in particular, time-related CD4, the most updated CD4 count that you have. Does that correlate with the development of multimorbid condition? The most updated viral load, not the baseline only, as well as adherence. For example, here you have adherence good or poor, which is nice. And it shows that, adherence is anyway time-bound event. It shows clearly here that there is increased risk of.
Maybe for this one, just to give a few reflection, especially with survival data, usually we stick to the baseline information so that we can follow prospectively. Otherwise, if we add the data maybe in the later section, like the updated, the recent one, it will bring the confounding effect. It will bring the correlation problems. That's why I just excluded the other observation, maybe just in the later parts of the follow-up. I just
no, you can include. There is no limitation with that. You can include them. Then if they are you can discuss them, and I can give you even Lancet papers published on Lancet, and even I had a publication on similar TB development among people treated with this. You could see some of my references also.
Yeah, normally I included the pilot study, but the limitation was it shows a significant correlation. That's why I discussed with my advisor and I excluded from the variables. That's why just even they recommended me to avoid other variables, especially in the later observation of the same variables. Rather proceed with the baseline.
Okay, so I assume you have three important time-bound variables: viral load, CD4, adherence. You can have a separate table for them.
Yeah.
And even did you get any opportunistic infection events during follow-up? I'm sure there will be some information.
Yeah. I just, for example, the chronic infection, the long-term infection, like tuberculosis was among the opportunistic infection, but I considered as the one of the multimorbidity components of the multimorbidity, since I just
so this TB, the tuberculosis, was that the prevalent TB which was at baseline, or the development of TB during
baseline? In the baseline, they didn't have a TB, but during the follow-up period, in the baseline, almost every individuals who are included in the study, they don't have multimorbidity at all. They don't have even a single multimorbidity,
Wow.
single
Okay.
comorbidity. I just
Oh, so you
exclude
got, you got 4 time-bound events, including TB then, which is nice to add. Yeah. You
Okay.
can have a separate table. It would
Okay.
strengthen your findings.
Okay.
Maybe something that you can do is here, Dr. Tsagga.
Okay.
It says yours program says MPH in epidemiology and biostatistics. So I think it's very important that you take, I don't know, further big steps into learning some statistical methods. So, I mean, if I was your advisor, I wouldn't advise you to refrain from using something that you would be able to learn from and something that's appropriate for your data. The Cox regression has a time-dependent variety. You can use the time-dependent Cox regression. You even used parametric model, which is very big. So using the time-dependent Cox shouldn't have been a problem. And the answer, the most important thing, something that I advise anybody is, as long as this research is in your name, whenever somebody asks a question, you can't just refer or blame it on somebody, right?
Yeah.
Because after a month or so, I don't know, after your defense, you're going to be on your own, you're going to be an independent researcher, and you should be able to have an answer for everything that you did, right? So
Okay,
I think, yeah, it's better to take that way. And one of the things, again, Professor David also mentioned it, you calculated a hazard ratio, and you're calculating the incidence doesn't change the fact that your outcome is time to event. It's a time to event outcome that you have here. These are, believe me, the comments that you're going to obtain when you submit your article for publication. So it's very important that you delineate what my outcome is, and you have tried to explain it, but relative risk and hazard ratio, there are analysis methods that you use for prospective longitudinal research, but the choice of the method depends on whether you are interested in survival outcomes or not. So you are interested in survival outcome, which is a time to event analysis. So that's why you have used adjusted hazard ratio, and the interpretation should also be revisited. By the way, you are saying that the risk of more likely, less likely, the risk of developing multimorbidity. It's not the risk. The rate of developing. You have calculated the rate of developing multimorbidity in a sense that you are also considering the time of development of the multimorbidity in your analysis, right? For relative risk, you don't enter the time dimension for the analysis, right? Because you are interested on the ultimate outcome. So you should also consider that. And the other, something that you have missed also is that for the log rank test, you just presented the p-values and the chi-square. Here we have a statistician. I hope this doesn't offend you. When I read articles written by statisticians, it's all about a number of tables with a number of statistical jargons. So as a clinician, and also considering that your audience is going to be a clinician and even other layman people, it's very important to bring together results into a more meaningful and acceptable tables and make it more precise so that the reader can understand it. So here you say that you have significant differences for the log rank test, except, I don't know, the one of the variables, ART regimen. But if I ask you what is the difference, you can't tell me, because it should have been presented with the median survival time for each subgroup of the variables presented here. So per occupation, you should show us the median survival time so that we can see where is the difference, which ones have better survival compared to the others. And on this table as well, you have compared incidence rates, and you have said that there is a higher incidence of multimorbidity among patients who are underweight and obese. And you say that it's a higher rate, but based on what? You do not have any comparison. Besides, look at the results. They all overlap. The 95% confidence interval of all the results overlap with each other. So without having a p-value, at least you did not even calculate the incidence rate ratio, the crude one at least, and you don't have any other evidence to say that there is a higher incidence here. So most of your statistical analysis, it's, by the way, for a medical student, Professor David also mentioned it at the beginning. It's impressive that you have gone this far and you did this with your first master's program. But we're considering that this is going to be a published article. It will add to the literature because it's very important. You have raised a very important research question. So I think you should also reconsider these things and revisit your analysis and make them more presentable, more understandable, and work with your interpretation and justifying the results. And especially here, I don't know how you're going to explain this. I haven't heard you explain this as well. So adding religion to a regression model and trying to justify it, I don't know how. I don't know. How do you interpret this result?
Maybe like in my study, I found that people, especially those Muslim religion and those with Protestant religion, they show that there is a positive association with the outcomes. But this study is, since it was a retrospective follow-up study, it has limitations because it's difficult to control all the confounding, even though whatever statistical approach I used and other techniques of stratification, other methods I applied, there is always a residual confounding. That may be the reason for this relationship between the Muslim religion and the outcome of interest. The other thing maybe there may be other factors, other socio-demographic factors, which is contributing for these outcomes. So it needs further research to justify the association. The other thing is, as you have mentioned, that the sample size was very, very small. Since in the other study, what I referred, it doesn't show any association, but mine was, since it was very small sample and it doesn't make a direct conclusion whether this Muslim religion brings on the multimorbidity or not. So it needs other studies, other further studies, especially
is it really worth conducting other research? I mean, what's your scientific base to even want to analyze this variable as an exposure? Besides, they both are now positively correlated. Muslims have a higher rate of developing multimorbidity and Protestants have a lower. So let's say if you have to recommend based on this result, what's your recommendation? I mean, we can't blame everything on the sample size, right? With the sample size, by the way, if you have a good distribution of your event and censoring among the subgroup of the variables, and if you have adequate number of events overall, you can get a good result even with a small sample size, right? And not only that, I was mentioning it, you were disconnected. So one limitation is that one drawback is that you should have included all patients from the chart because it's already 1,154. It's a small sample size, overall eligible participants. From that, so many were excluded. And finally, you decided to calculate a sample size, and because of the eligibility criteria, you have dropped like more than 10% of the required sample size. So with this, no one is going to accept your result. It's not adequately powered. So at least even at this point, what you can do is you can go back and do the post-hoc power analysis and show if with this sample size, with the unplanned sample size, the 454, if it's at least adequately powered enough to answer your question, given the outcome that you have already obtained. So, at some point we're trying to defend the sample size, and at some point we're trying to blame every problem on the sample size. So my recommendation is, and as long as there is no scientific basis to even consider this variable as an exposure for this particular study, it's better to remove religion. Even one of the things that I wanted to say is that our choice of variables is not always should not always be limited by the statistical significance. Sometimes we have to see the variables, and if we don't believe that they're not going to add anything, we should drop them. And if we believe that the variable is very important and should be controlled, even if it's not statistically significant, we can consider it by the rule of clinical significance, right? So the choice of variables is in your hand, and I don't see how this is going to be, I don't know, explained.
It's very sensitive points, but since it was my first work in just conducting this kind of research, I just have some limitations to go with the variable selections of variables. Even to omit some variables, it changed lots of things in the overall outcome of the research. That's why I just have limitation, but I'll check the research again. Okay, I'll check the result part again. Okay, I'll take it as a comment. Thank you. Maybe from the initial question regarding the model selection. Initially, I ran the regression using the Cox proportional hazard, but the limitation was when I checked the overall goodness of fit, it violates. So I just try to check which variables are violating the assumption. So those variables to violate the assumption, the proportional hazard assumption, will be done or conducted by the parametric models because it doesn't fit for the proportional hazard model, the Cox model. That's why I just run with using the parametric model, the Gombardas. There is almost five models in the parametric. So I have to make decisions which one should I use. I stick to the Akika and Bayesian information criteria. So based on the Akika information, I selected the Gombardas model. So I proceed with the variables which violate the Cox proportional or Cox regression. Was the variables, some variables are regressed with the Gombardas regression model. That's why maybe you raised the question ahead. Hello?
Yeah, we're listening.
Hello?
We're listening, Dr. Zaga. Professor, do you have anything to add? And Dripsa will also give you...
Yeah, maybe you noted
Okay.
my concern. You know, your outcome is multimorbidity, more than 2 diseases, yes? Am I right, Dr. Zaga? I think he disappeared.
He's still on, maybe.
Yeah, is there? Yeah, so maybe
Okay.
Dr. Tegist, can I take 1 minute?
Yes, please do.
Okay. So thank you, Dr. Tagga. I'm not sure if you can put me up. So I have like maybe one major comments and maybe one or two reflections. So regarding the survival model, like if your outcome of interest is time to a particular event, maybe what you have said become like probably correct. But when the assumption of proportional hazard is violated, or if the assumption of Cox region is violated, it is possible to go for the parametric survival models. But the problem, most of the time, we can compare like uncomparable models in parametric survival models because of their like assumptions. So, for example, exponential, Weibull, they have different. So comparing these two models means sometimes we are like comparing an uncomparable model. So we have, I think, be serious on that. The other thing is, I'm not sure if he like have done handling missing data, checking the interaction effects, and the other thing is he can also normally consider time varying covariates like what Prof said. So normally the way we do the analysis with the time varying covariates is totally different from the usual one. So the coding, everything is different. So maybe he can approach a senior statistician or a programming expert, so that he can estimate the relative risk or hazard ratio at each time point, and finally maybe we can get like totally different result with the model he has used. And the other thing is Dr. thinks about the multicollinearity. So like if we have like categorical variables in our models, our model, we can like check the problem of multicollinearity, but the way we do is different from the way we do for continuous variables. So let's say we have like one categorical variable with two categories and the other categorical variable with 4 or 5 categories. So what we can do is we create like dummy variables for the variable with more than 2 categories. Then we can run either like logistic regression so that we can get the modified form of the R square so that we can still calculate the variance inflation factor. So there is like a little bit modification in doing that, and we can still check multicollinearity problem for category.
Dr. Zaga? I think, Dribsa, are you done? Prof, if you have anything to add, please add, and we can conclude the session. I think due to the connection problem, it has been a very long and exhausting session, and we're really sorry for that. So, Prof, if you have anything to add, or as a concluding remark, let's hear that. And
oh, really? Okay.
Your mic is mute, Prof. I think